And we're back, ladies and gents, with another Health Matters podcast. And today we're joined by our phenomenal doctor, Dr. Zenda, widely known as Dr. Gynae, and of course, Johannesburg-based OB-GYN sexologist, founder of We See You. As a fellow of the European Committee of Sexual Medicine, Dr. Zenda continues to break stigmas and, of course, lead transformative conversations around women's reproductive health across South Africa. In this episode, we're going to dive into one of the most commonly misunderstood conditions in women's health, Polycystic Ovary Syndrome, or PCOS, and endometriosis. Although both can affect fertility and cause chronic symptoms, they are obviously distinct in their causes, their diagnosis, and the treatment paths. From hormonal imbalances to painful periods, missed diagnosis to fertility changes and challenges, these conversations are essential for anyone navigating reproductive health or supporting someone who is. Now, whether you've been recently diagnosed, suspect something isn't quite right, or simply want a better understanding on women's health, specifically this episode will equip you with clear insights, empathy, and of course, expert advice. Doctor, welcome.
Thank you. I hear it's chilly in Joburg, but Cape Town is apparently worse.
It is indeed, the winter and the throes of which are currently taking place. Doc, PCOS and endometriosis, these are big things to be diagnosed with. First of all, let's talk about how they differ.
Right. So polycystic ovarian syndrome specifically affects, the reproductive system, but it also involves the cardiovascular system. It involves dermatological because of the symptoms that come through. And it is largely an endocrine plus reproductive, condition. Whereas and polycystic ovarian syndrome in itself, there is no pain. So that's one of the cardinal big differences. Generally, there's no associated pain necessarily that is associated with PCOS. Whereas endometriosis is predominantly a reproductive system issue or condition that affects the reproductive system. And it may affect the rest of the sort of like the internal organs, because that's basically what endometriosis is. It's the lining or parts of the endometrial lining spilling into where it should not be, which is inside the abdomen or the stomach, and therefore doing the same kind of movement or what I call it's contractions, premenstrual contractions. Now you've got all these tissues that are inside the stomach and doing the same thing, causing all these other problems. So that's the big distinction. One of the big cardinal symptoms of endometriosis is debilitating pain premenstrually and even during menstruation.
Doc, what are the known causes behind each condition?
Right. So, not surprisingly, but for the both of them, there seems to be a definite genetic factor. So, if it is in the family, so for both of them, then when you particularly look at endometriosis in itself, if you look at all the research, it will start off by saying we still don't know the exact cause or how it happens exactly, but there are definitely theories. One of the most common one is the fact that we see the endometrial lining tissue, which is what basically gets passed out as your period. Some of that, it's almost like a retrograde through the tubes into the stomach. So you're getting endometrial tissue that is deposited where it's not meant to be. There are theories of sort of like an autoimmune, sort of like underlying autoimmune process that is there. When it comes to polycystic ovarian, it is definitely genetic in its cause, but it is also very much associated with lifestyle. If you look at some of the impact that it has, we spoke about cardiovascular, metabolic, sort of like dysfunction where you've got insulin resistance. So it kind of polycystic lends itself together with a lifestyle associated with that. Over and above that, polycystic has a hormonal factor to it where there is hyperandrogenism, or simply put, you've got more, as a woman, you've got more of male kind of hormones, like higher testosterone than what women should. All women have some level of testosterone, but when you have more than what you should, it kind of tips the balance of what is happening there hormonally. And that's why you get then the symptoms, like, the sort of like male, I would call it male symptoms, like growing hair and what we call hirsutism in places of kind of male distribution. But I'm sure we'll get to the symptoms in a bit.
Absolutely, because next question is going to be, I mean, how is it diagnosed, or rather, how is it misdiagnosed?
That's one of the difficulties with both conditions, is that very often it is missed for the longest time. If you look at endometriosis, partly I believe it's because there is this sort of normalizing the idea that painful periods are normal. Painful periods are common, but painful periods are not normal. If a period cramps are not alleviated by a simple analgesia, already that is a big alarm bell. And also the one other big thing is when you are unable, or the pain is debilitating, lasting during the premenstrual, which is anything between 7 to 10 days prior to your period and going on into the period. Now, the other thing that becomes important with endometriosis is part of the reason it gets diagnosed late is because very often by the time people recognize it or it's diagnosed, if perhaps maybe say a patient has been from one doctor to the next, they get given painkillers, they kind of grin and bear with the pain. When you get into your adulthood, particularly when somebody starts being sexually active, then those things can come up. So painful sexual intimacy, coupled with also if it has grown to a stage, particularly past stage 2, where now it's involving the destruction of your actual reproductive organs, like the fallopian tubes, or the tubes, basically, and therefore leading up to leading up to infertility. That's when people very often then are kind of like, oh, something is actually more wrong than I realized for the longest time. So the important thing about endometriosis is that painful menstrual periods are common, but they are not normal. Go and check in with your healthcare provider. When it comes to polycystic ovarian syndrome, in terms of how it's diagnosed, and by the way, just on the endometriosis, for actual diagnosing of endometriosis, we have to be able to put cameras in. So what we call laparoscopic diagnostic procedure. And it can be dual in that you can diagnose and treat at the same time. We put in cameras, we actually see what is happening. So the symptoms will be suggestive and lead up to, and if healthcare providers are watching, especially more junior, please, if a client is complaining and you've given them pain medication, send them to a gynae, let them have a laparoscopic diagnostic laparoscopy, and maybe therapeutic if to diagnose it properly. Polycystic ovarian syndrome, on the other hand, there is a criteria that we use, which is called the Rotterdam, which is basically looking at 3 things or 3 criteria. When you are just home kind of wondering, do I have it or don't? One of the big things that is likely to happen, particularly once you've, we kind of say, if you've had your period, let's say 3 years after what we call the menarche, or the debut of your period should kind of start to normalize into a cycle of anything between 21 and 35 days. The younger adolescents, sometimes their periods, as their hormones are balancing out, may be a little bit longer. But once you've kind of settled into that period, every woman should have a cycle that is between 21 and 35 days. If you're having a cycle that is longer than 35 days, or sometimes what we calculate as less than 8 cycles per year, then that is suggestive of some kind of an irregularity. It does not necessarily mean that you've got polycystic, but it is a sign that you should, talk about with your healthcare provider. The second part of the diagnostic criteria is polycystic ovaries. Now, this you will not be able to see it for yourself. It's something that we do a transvaginal exam. We'll look at the ovaries themselves. We'll look at you can look at the volume of each ovary. We can look at the number of what we call follicles, because what happens every cycle, your ovaries, with the influence of the hormones, it kind of raises up a couple of those follicles. 5 to about 11-ish is what we look at as normal. You can actually see very clearly, it almost looks like sort of like a pearl necklace. So you sort of like a congestion of these follicles, which means there is an ovulation, dysfunction. You're not able to, you've got the eggs, but they're not able to be, pushed out of the ovary. The last one is hyperandrogenism. Hyperandrogenism, as I said, is the increased amount of the male, hormone testosterone in this case. Now, this one can be looked at from a clinical perspective, meaning you can have symptoms that are suggestive. For example, we've spoken about what we call hirsutism. So hair growing in sort of male, distribution. They may even get balding. Things like, they may have acne, and something where, basically a dermatological condition, that we call, acanthosis nigrans. So those are the clinical that the patient can see for themselves. But we absolutely 2 out of those 3 criterias diagnose polycystic ovarian syndrome.
Okay. Doctor, how do these, we talk
Mouthful,
about...
hey?
It is, but a lot of very interesting facts here, because we realize that both of these affect fertility differently. So let's talk a little bit about that.
Yes. When it comes to fertility,
yeah.
How do they? Yes. So with polycystic ovarian syndrome, the big thing is if you're not ovulating, if that egg is not coming out, no matter how amazing the sexual intimacy is, you're not going to fall pregnant. So it is an ovulation dysfunction when it comes to polycystic ovarian syndrome in terms of how it causes infertility. When it comes to endometriosis, on the other hand, it is the destruction of the reproductive system. So you may get what we call chocolate cyst, or basically a hemorrhagic cyst, where a cyst twists and bleeds inside. But the other big thing that happens is the destruction of the tube. If the tubes are destroyed, it's not that you cannot fall pregnant. It means we may have to do, artificial, reproductive assistance, to support that. Yeah. And with endometriosis, the other big thing is that you'll find that it's not only the reproductive organs that, especially the higher the classification, then you've got difficulty, your bowel gets involved. Even something as, because of the pain factor with endometriosis, it might not even be as far as infertility. It might be difficulty in having sexual intimacy, avoidance, and then it creates that pain cycle of pain and avoidance. And therefore, if you're not having sexual intimacy, if you're not enjoying sexual intimacy, the likelihood of you kind of committing to, okay, we are trying to fall pregnant. But those are fundamentally the 2 differences in terms of how it poses a threat to conception.
What treatment options are available? I'm listening to this, I'm going, oh my word, this could be me. And if so, what is there available for me?
Right. The first thing, even just before we get to the treatment options, I always encourage women, please, you don't have to be sick or something wrong for you to go and see your gynae on a regular. Once a year is fine, because then we're able to pick up these things. You're able to pick up the changes. Sometimes we'll find a woman hasn't even noticed that their cycle is actually longer than it's supposed to be, because life happens. So when you do go and make sure you do your check-ins. How do we treat? Let's start with endometriosis. Endometriosis, you always want to start conservatively and move upwards, because like I said, a person who comes in first complaining of painful menstrual cramps, you want to be able to start with simple analgesia. You want to be able to determine that is this really does it really warranty further investigation? As I say, diagnostic, once it's been diagnosed laparoscopically, one of the important things that we do is actually, for a lack of, in lay terms, we basically we remove and burn the endometrial tissue that we find. Prior to that, or together, or in conjunction with surgical management, we may give you a hormonal treatment, particularly starting with something as simple as a combined oral contraceptives. And now we've even got formulations that have got a progestin that is specifically really good in terms of that pain alleviation and basically keeping that immunity or that inflammatory response as low as possible. That is endometriosis. When it comes to, and then, laparoscopic surgery for endometriosis also depends on the extensiveness of the endometriosis. It may include removing and burning the endometrial tissue. It may include, what we call adhesiolysis, where if there's been adhesions of the reproductive system to the bowel, to the other organs, we kind of dismantle that as well. When it comes to polycystic ovarian, polycystic is a I would say a tricky one, not because it's difficult to treat, but because this is the one that needs the client or the patient to be fully involved. From the perspective or from the side of the clinician, we may start off with things like just start by managing if there is a weight issue, because part of the reason sometimes not all polycystic ovarian patients are overweight, but for the vast majority, you find that is a factor, particularly with an enlarged waist circumference. So it is important to manage the lifestyle, but also check the risk or rather assess for the metabolic side. That's why it's also a multidisciplinary team that is necessary. You need an endocrinologist that will come into the picture, and we check things like your insulin resistant, what are your sugar levels looking like, cholesterol and the likes. And in terms of actual treatment, we may again, start off with something to help with ovulation, a hormonal, combined hormonal contraceptive. We may give something that we generally would use for patients who are diabetic. So something like a metformin, for example, we may give that to assist. But the bigger part of it is adjusting and helping your body to, one, be able to get that sugar transported in the right place, decrease the insulin resistance. On the other hand, we want to be able to lower down the amount of that androgen that is in the system so that it can help kickstart. There are surgical procedures that can be done with the medical or the conservative in polycystic ovarian syndrome and not working. So we do something we can do something called drilling or wedging, where we basically it's almost like you're trying to crack open the ovary to get the follicles out. But for the most part, the difficulty with polycystic ovarian syndrome is that there is a big effort that has to come from the client in terms of managing the health or rather the lifestyle, habits, things like, I don't believe in move more and you lose more weight. Sometimes,
Sure.
You may even get to a point, if the BMI is so high, we may consider even medication, weight loss medication, things like the semaglutides and the likes. So it is managing that whole aspect. Over and above, for both of them, something that we often neglect is the psychological impact from the endometriosis side. From the endometriosis side, pain in itself can predispose somebody to depression, anxiety, sexual dysfunction. From the polycystic ovarian, it is the body image plays a really big part. It can impact on the self-esteem. So a lot of psychological support is also very important. and family education. I always say, we always forget that people come from families, and it's important to educate the family around you so that people understand what you're going through. If you have endometriosis, you have a partner, you have a husband, it is important for them to understand it's not because you don't like them much. It's that really the pain is that excruciating, and it's always good to do that counseling with the partner as well, so that they understand what it is. They understand when it's at its worst, particularly with endometriosis around the time of the premenstrual and the menstrual phase. And over and above that, all the ways that they can support you, assist you in just understanding and finding other ways of being intimate if, at that particular moment, the pain is prohibiting things like penetrative intimacy.
Doctor, this is something that's been so close to my heart with a wife and a partner that's had endometriosis and PCOS. And as a partner, you do really need to understand every single aspect about what this is and what your partner's going through. Because often, to your point, when it comes to hormonal treatment, you, as a partner, if you aren't understanding, you can understand why. In many cases, it leads to things like divorce. Because if you're not in that space where you're able to accept what your partner's going through, understand what your partner's going through, and then be that support for what your partner's going through. It's so crucial, especially in fertility treatment. And the other thing that kind of struck me was that endometriosis, if you have it and you've had it removed, it can come back. You can have multiple laparoscopies to have it removed. So you need to be checking yourself regularly, ladies and partners. You need to be as supportive as you can be to your partner going through either PCOS or endometriosis, and have the patience, because sometimes, we want a quick fix for things, doc. We want things to happen immediately. We want to go. We want to have babies. We want things to just be, be as it should be. But life isn't like that. And these things happen, and we need to be understanding of that and supportive as much as we can be. So, partners out there, I hope this has been some help to you. We're with an incredible Dr. Zenda again, who's been unbelievable in just explaining a little bit more on the subjects of PCOS and endometriosis. So, doctor, thanks for your time.
It is always such a pleasure, and I hope this will help somebody.
Absolutely. Don't stop talking about this. If you're watching this, please share this with your friends, share this with your family, and don't be afraid to talk about it. Join us again on our YouTube channel. We're all over there. Health Matters, proudly brought to you by Cipla, for more episodes and conversations. And until next time, listen to your body, ask questions, and never settle for silence when something doesn't feel right. Take care.